Hey everyone, so this is going to be the second lecture in a series of 4 on your reproductive content. So this part is going to cover your intrapartum care, which is my favorite to lecture on. We will be adding some stuff or kind of using some application activities in your live session. So I do understand that some of this information that I'm going to give you is going to be a little bit tedious, and it's going to take probably applying it to make it really stick with you. But we're going to get started and cover what we need to so that you'll be prepared for your activities in your Zoom session. So intrapartum is going to be the period of time that's going to be when the patient is in labor. So you're in the hospital, and there's a lot more monitoring or some special things that we have to do during the intrapartum period to make sure that the mom and the baby are safe. So this doesn't take the place of a good old-fashioned head-to-toe assessment, although this is kind of going to be added on to it. So one of the things that we have to monitor very closely when a patient comes into labor and delivery is going to be contractions. So contractions are just what you think they are. They're going to be contractions of the uterus, and the whole point of having contractions is to deliver a baby. So we want to make sure that we're monitoring those very closely. So there's two main ways that we can monitor for contractions. So the most common way that we do that is something called an external monitor. So it's non-invasive. It's called a TOCO, and the TOCO actually sits on the top part of the uterus. So if you remember from your antepartum lecture that the top part of the uterus is called the fundus. So this will actually sit on the fundus. So when we did that fundal height in antepartum, we kind of use that as well, because if they come in and they're 36 weeks, then we should know about where the fundus should be so that we'll know where to place this monitor. The key thing with this is that even though this will test or tell us how often they're contracting, which is the frequency, and it will also tell us duration, so how long each contraction is lasting, what it does not tell us is how strong those contractions are. So along with the external monitor, the nurse is going to use a palpation technique to be able to determine the strength of those contractions that the mom's having. So it's kind of funny, it's going to look kind of funny to do this, but if you're palpating a contraction, there's kind of a funny little way that you can see what it should feel like. So contractions are usually gauged as mild, moderate, or strong. So a mild contraction is kind of like touching your nose, where it's kind of squishy but then it gets hard. So that would be a mild contraction. A moderate contraction is kind of like touching your chin. So you can definitely tell there's a little squish to it, but it's pretty much hard. And then a strong contraction is like touching your forehead. So the abdomen does change, and you can palpate those changes, and based on what we feel, we can decide if we think it's a mild, a moderate, or a strong contraction. So if you're using an external monitor, the nurse also has to be palpating for strength. There is an internal version of contraction monitors that are only placed by the healthcare provider, and we don't use them very often because they do carry some risk and they are invasive. But the internal monitor is called an IUPC, which stands for intrauterine pressure catheter. And it tells us everything. It tells us the frequency, the duration, and the strength of the contractions. So there is some benefit to having that in place, but we don't always place those because it does carry some risk with it as well, and it's not scope of practice for the nurse. So by far, the most common way that we're going to check for contractions is going to be external monitoring. We also have to monitor the fetal heart rate. So there's 3 ways that we can do this. So in your antepartum, typically the way that we monitor the fetal heart rate is going to be by Doppler. If they're coming into the office, we're just going to kind of do a spot check. But in the hospital, we tend to use the external ultrasound monitor so that we get a continuous strip on the baby so that we can tell what the baby's doing at all times. So the external monitor is known as an ultrasound monitor. It does require ultrasound gel. So if you look at the top picture there, the one that's on the left-hand side is the TOCO, and the one that's on the right-hand side is the ultrasound. So you would put ultrasound gel on that, and you're going to place the external ultrasound monitor over the fetal back. So you'll see the nurse kind of palpate the abdomen. She's trying to locate where she thinks the fetal back is located, because that's where that monitor is going to trace most efficiently. So the external ultrasound monitor for fetal heart rate is placed over the fetal back. There is an internal version that we can use to monitor the fetal heart rate. It's called an ISE, or an internal scalp electrode. It is scope of practice for an experienced registered nurse who's been checked off to place those, but only if the water has already been ruptured or already been broken, because that is not scope of practice for us to break water. And the way that little internal monitor is, it actually kind of it sounds terrible, but it screws under the infant's skin and the scalp. So it doesn't really hurt them, but it does have a very thin little, it looks like a little spiral screw almost, and that'll kind of go up under the skin. That's how it traces. So it is an invasive procedure, and it's only used when we can't trace the baby by other means. So it's definitely not the most common way that we use. So just to be clear on this, most commonly you're going to use the TOCO for contractions placed over the fundus, and you're going to use the ultrasound for fetal heart rate placed over the fetal back. The picture on the bottom right shows those internal monitors, and I'm hoping that by the end of the semester we can get in to do some simulation, and I will show you those monitors, but it's not something we frequently use. So when you're looking at contractions, when we get a printout of contractions, this is kind of what it looks like. And this is just on here to kind of talk about some terminology that you might see and how you could use that in studying and that kind of thing. So if you look at that contraction, it kind of looks like a mountain. It has an increment, which means it goes up. It has an acme at the peak. So the acme of a contraction is the peak of the contraction. And the decrement is where the contraction starts to subside. So the biggest term that you need to know from that is the acme, or the peak of the contraction. So I would normally call it the peak, but I don't want you to miss HESI questions or board questions because it calls the acme. So the acme is the peak of the contraction. In between the contractions, you see something that says resting. So remember we talked about with an external monitor, you're going to put it over the fundus, but the nurse is going to have to palpate for strength. So something else that we need to palpate for is to make sure when they're not contracting that they actually are getting some rest in between those contractions. So that rest period or resting tone is going to be the period in between contractions when that abdomen should return to a non-contraction state or be soft. So the resting tone should be soft. You'll also see a couple other terms on there, duration and frequency. So those are things that we measure in labor and delivery, but it's also something that we might ask a patient to check on themselves to see if they need to come into labor and delivery or to time their contractions. So duration is going to be how long the contraction lasts. So if we're going to teach a patient how to assess the duration of the contraction, then you're going to tell them to time a contraction from the beginning of one contraction to the end of the very same contraction. So that would be your duration. For your frequency, it's how often the patient is contracting. So you're going to tell the patient to assess the time from the beginning of one contraction to the beginning of the next contraction. So that's going to be the frequency. And that's typically what we ask patients to assess if we're trying to figure out how close together or how many contractions they're having, is we'll tell them to assess the frequency. But it's very important that you know how to notice that on a strip, but also how you would notice that in a word form. So this kind of goes over what we've already talked about: frequency, duration, resting tone, how strong they are. So once we've kind of evaluated our contractions, the next thing that we have to evaluate is the fetal heart rate. So one of the things that you're going to evaluate with fetal heart rate is the fetal heart rate within a normal range? So first things first, when you look at a fetal heart rate strip, you're going to decide if it's in that normal range. So for a baby, the fetal heart rate is much higher than it is for us. So for a baby, the fetal heart rate should be 110 to 160. So that's the first thing that you're going to assess for. The second thing that you're going to assess is going to be the variability of the fetal heart rate strip. So this is something that students tend to, it's a little bit harder for students to grasp this, so I'm going to say it in a couple different ways to see if I can get it to make sense for you. So when you're sitting here or you're watching this video and you get up to go to the bathroom or to move around, your heart rate is going to fluctuate. That's a good thing. That's a response that it should have. So a baby should also have some fluctuation in their heart rate, because remember, they're not just in there not moving, they are moving around inside that amniotic sac. So they should have some fluctuation in their heart rate. And babies can't tell us what's wrong, so we have to look at what we can assess, like fetal movement or fetal heart rate variability, to determine how well that baby is doing inside of mom. So the variability is how much fluctuation there is in the heart rate. So I'm going to give you the numbers first, and then we're going to kind of go back and talk about it again. So absent variability is going to be 0 to 2 beats of fluctuation in the heart rate. So just write it down first, and then I'm going to give you some examples. So 0 to 2 for absent, just so there's no overlap. And then for minimal, we're going to do 3 to 5 beats per minute. For moderate, we're going to do 6 to 25. And for marked, we're going to do greater than 25 beats per minute. Okay? So if I were to give you a fetal heart rate strip, you can kind of see that one on there, that it looks like there's just not much going on with that heart rate. It just kind of looks like a straight line. So if I was going to give you that in a word form, it would be equivalent to me saying that the fetal heart rate is 120 to 121. So 120 to 121, there's 1 beat of difference. That falls within the 0 to 2 range. That makes it absent variability. For minimal, there's a little bit of fluctuation, but not a lot going on there. So that would be like me giving you a fetal heart rate on a test that's 130 to 133, or 134. So let's do 130 to 134. That's 4 beats of difference. So that would be minimal variability. For your moderate, if I told you on a test that the fetal heart rate was 140 to 150, that's 10 beats of difference. 10 falls within the 6 to 25 range. That makes it moderate variability. And marked is pretty easy to pick up because it's extremely chaotic. The heart rate's just all over the place. It's almost like it's really difficult to even determine where the fetal heart rate's at most of the time because it's so chaotic. But anything over 25 beats, so if I told you it was 110 to 140, that's 30. So that's going to be above 25. So if it's very varied, then that's going to be marked variability. Here's what I need you to know about your variability. So you're not going to look like, just like you look at the heart rate, you can't look at abnormal parts of the heart rate strip, and I'm going to show you some differences on that shortly about A cells and D cells and that kind of thing, and it'll make more sense. But you have to check the fetal heart rate baseline, not in an acceleration and not in a D cell. So when I show you the strip, that'll make more sense. So absent variability, not good. It means our baby is not real happy. So if a baby is continually having absent variability, that could be an indication for a prompt delivery by C-section. We don't like to see absent variability. Minimal variability is kind of the gray area. So just like you and I, if we were to lay down and take a nap, our heart rate doesn't fluctuate as much. So a baby can do the same thing. So if you've given mom some medication that sedates her and that it's going to sedate the baby, then minimal variability is okay at times, but they should not have nothing but minimal variability. Your moderate variability is what we like to see. That means our baby is happy in utero right now. So moderate variability is good. And marked means that there's something going on inside, so we need to make sure we fix it. Sometimes we'll see that with a blood pressure drop in the mom or something like that. So it usually is just an indication that we need to do a good assessment, find out what's going on, because we may need to intervene and do some things. So absent bad, minimal's the gray area, moderate's good, marked is not good either. But of all of them, absent's the one that you absolutely do not want. So once we look at the variability, then we're going to look for A cells and D cells. So if you accelerate in a car, you speed up. So this is going to be an acceleration of the fetal heart rate above the established baseline. If you decelerate in a car, you're going to slow down. So this is going to be a drop in the fetal heart rate. And there's 3 types that you need to know. So I'm going to discuss them here, and then I'm going to show you a slide on the next one, an easy way for you to remember it and what it means and those type things. So early D cells are going to mirror image the contractions. So if you look at A on the slide, you can tell that the bottom part of that is your contractions. So this part right in here would be your contractions, and this is your fetal heart rate. And you will see that there is a deceleration with each contraction, but it kind of mirror images the contraction. So your earlies are going to mirror image the contraction, meaning that when the contraction starts, the heart rate starts to drop, but when the contraction ends, it's already back up to its previous baseline. So earlies are going to mirror image the contraction. And earlies indicate head compression. So if a mom is giving birth, we expect that that baby is going to come down into the pelvis and there's going to be some pressure applied to the head because it's a small opening that they're coming out of. So early decels are not a bad thing. They kind of tell us that labor is hopefully progressing. Your variable decels are going to be number C, or letter C. So this is going to be your variable decels here. So with your variable decels, they are very abrupt. They look like V's or W's or U's, but they drop really, really quickly. So see how fast that one drops and that one drops? So your variable decels are very abrupt. They're very abrupt to drop the fetal heart rate, but they're also usually very abrupt to come back up. So you can tell even with this one, even though it lasts longer, it jumps back up pretty quick. Those can occur with or without contractions, but most of the time we do see them with contractions. And your variable decels are going to indicate cord compression. So somewhere that baby's cord is being compressed in some way. The last type of decel that we're going to talk about is going to be your late decels. And your late decels kind of give you a hint. So if this is my contractions here, your late decelerations are going to start to drop at or after the acme or the peak of the contraction. And by the end of the contraction, they're not going to be back up to baseline. So they're going to occur late in the contraction. So if we look here on this one, here's where my contraction goes up. Here's the peak of my contraction. And I'm starting to have a decel. But my contraction ends right here, and I'm still in a decel. It actually doesn't go back up to baseline until right before the next contraction starts. So late decels are going to occur late in the contraction. And of all three, your late decels are the worst ones to have because they indicate placental insufficiency. And we know that the placenta is kind of what does everything for the baby. It oxygenates the baby, it removes waste products. So if it's not functioning properly, then this is going to be what we see in a baby to tell us that things are not okay inside and we need to do something about it. Okay? So early is okay. Head compression, hopefully labor is progressing as it should. Variables are cord compression. Got to do some intervention. Lates or placental insufficiency, definitely have to do some interventions. So normally if we were in class, I would write this on the board. So I kind of drew it on my whiteboard at home and took a picture of it and put it on the PowerPoint so that we can talk about, so you can see everything in one little area. So this should be something that you commit to memory. So you're going to take a piece of paper or on your notes as you're sitting here listening to this, and you're going to go through and you're going to write the acronym VIL-CHOP in 2 columns, 2 vertical columns, just like you see on the board on the picture. So when we're doing a fetal heart rate assessment, the VIL part is what you're actually going to assess in the baby. Variable decels, early decels, or late decels. And then the A cells are going to be your A. So let's go through these one by one. So variable decels, very abrupt, maybe with or without contractions, but they indicate cord compression. So the CHOP is going to be your pathophysiology. So variable decels indicate cord compression. Your early decels are going to indicate head compression. We love to see accelerations. That's a great thing. So those are okay. They make us happy. And then your late decels are going to be placental insufficiency. So along the bottom, you have your contractions, you have your fetal heart rate, and then you can see how those decels look based on the contractions that they're having. So the bad thing, or I guess good thing for testing purposes, because there's only a few things that we can do for these decels. Bad thing for us as nurses, because sometimes it's frustrating because we want to be able to make everything better and we only have a handful of things that we can do as far as nursing actions. So the things that we can do are things outside of mom that will help inside the uterus or with the baby. So one of the first things that you'll see us do is change position. So most definitely for cord compression, that's going to be your first action, but really for any of these that need intervention, so your variables or your lates, position changes are always good, but it does matter what position you put them in. So we do not want our moms flat on their back because that causes a vena cava type syndrome where they get compression of the vena cava, and that's going to decrease blood flow to mom's heart, which is going to decrease blood flow to the baby. So no supine positioning. So very seldom do we ever say in nursing school, absolutely no. But with pregnant patients, you will not place them supine. So positions that would be appropriate for these moms are going to be lateral positions. So left lateral is preferred, but right lateral is okay. So a lateral position, because that displaces the uterus and it helps with blood flow. So lateral position changes. We can give them an IV fluid bolus. So typically for a laboring patient, you're going to see us do lactated ringers or normal saline if they're gestational diabetic. So we could give them a 200 to 300 or maybe even 500 cc fluid bolus if indicated. The next two kind of go hand in hand. So Pitocin is a medication that causes contractions. We use it all the time in labor and delivery because a lot of our patients are inductions, and that's the medication that we use to induce them. But if you're going to have to turn that Pitocin off because the baby's not tolerating labor, then let me rephrase that. If you're going to have to apply oxygen because the baby looks bad, then you should also turn off the pit. So those usually go hand in hand. So if you feel like that fetal heart rate strip looks to the point where you need to apply oxygen to the mom, then you're going to turn the Pitocin off as well. Typically for adult patients that are not pregnant, if we're going to apply oxygen, we start low and go high. But for a mom, it's not an oxygenation problem with the mom, it's an oxygenation problem in the placenta. So for your oxygen for pregnant patients, we typically use a non-rebreather mask at 10 to 12 liters oxygen. So we're not going to start little and go big. We're going to just give them a non-rebreather to start with. And then we can always call the physician. So depending on what's going on with the patient and what we're seeing, it may be a call to the physician to say, hey, I did these interventions and now we're better, or it could be a call to the physician to say, hey, we really need you here now. So it just depends on, you can be giving them a call as an update or as a, hey, I need you to get here now kind of thing. So just to kind of go back over the nursing actions, so position changes to a lateral position, IV fluid bolus. If you're going to apply oxygen, it needs to be non-rebreather at 10 to 12 liters. Turning the Pitocin off is okay, but if you have to apply oxygen, the Pitocin definitely needs to come off. And then calling the MD for further orders or further actions. So this is something you can kind of commit to memory and use on a test because it will come in very handy from here on out. So this is an actual fetal monitor strip. So all this stuff that we've been talking about kind of is all on this strip. So if you'll look at the bottom, it says contractions. So the way we would calculate frequency and duration, you can see if we're doing how often they're contracting, you would count or measure from the beginning of this contraction to the beginning of this contraction, somewhere right in there. So each one of these little boxes is 10 seconds. So I could count it and go 10, 20, 30, 40, 50, 60, 70, 80, 90, so on and so forth. So I could count from the beginning of one contraction to the beginning of the next, and that would be my frequency of contractions. I could also count the duration by looking at one single contraction. So if I looked at this one, if my contraction starts about here, I would say 10, 20, 30, 40, 50, 60, 70-ish. So this contraction is about 70 seconds long. So if you're going across this way, it's going to be 10-second increments. The top part up here is going to be where we assess fetal heart rate. So this is your fetal heart rate baseline. So the baseline is where it is the majority of the time, not in an acceleration and not in a deceleration. So you're not going to count it from here all the way up to here. That's an acceleration. That's an acceleration. This is a decel. So you're looking at where it is the majority of the time. So if you're going to do the fetal heart rate and get the variability, this is kind of the section that you need to look at. Okay, so let's take it even a little bit more specific and look at it from right here to right here. So if I looked at that little section of fetal heart rate, all this is going to go up by 10 beat increments. So here is 120. This is 130. That line right there is 140. This line is 150. So if we look at just this section right here, I would say that my fetal heart rate is 140 to 150. So 140 to 150, that is within the normal range of 110 to 160. And I can also tell, because I've got 10 beats of change in the heart rate, that I have moderate variability. So my heart rate is 140 to 150 with moderate variability. The next thing I'm going to look at is, do we have accelerations? And we have 2. Here is 1, and here is 1. So we have 2 accelerations. So let me talk a little bit about the accelerations. Remember earlier on the antepartum period when I said we'll talk about NSTs when we do intrapartum? So here we go. So with your NSTs, this is basically what we do for the patient. We would put them on the monitor and we would get a strip. So the first thing I'm going to tell you is the criteria, and then I'm going to explain it. So just write this down. So to be reactive, to have a reactive non-stress test, which is what you want, you need to have 2 15 by 15 accelerations within 15 to 20 minutes. So I'm going to repeat that one more time. So to be reactive, which is what you want the fetal heart rate strip to be, you have to have 2 15 by 15 accelerations within 15 to 20 minutes. So if we say that our fetal heart rate is 140 to 150, the average of that would be 145. So when I say 15 by 15 acceleration, I mean a heart rate that goes up 15 beats above the established baseline and lasts for 15 seconds. So if we're saying our heart rate is 145, you would have to add 15 beats above that, so you would do 160. So we're saying that the patient has to have an acceleration that at least goes to 160 and lasts for 15 seconds. So if we look at this one, this is 150 here, this is 160, so that one looks like it goes to about 165. So it meets one of the criteria, so now we have to see if it lasts for 15 seconds. We said down here that each box going across is 10 seconds, so essentially it has to last a box and a half, and this one lasts 3. So this acceleration would count as one of our 2. So let's see if this one over here counts. So it has to hit at least 160, so this is 150, this is 160, again that one looks like it hits at least 165, 168, somewhere around in there, so it meets that criteria, and it also lasts a little over 3 boxes. So by definition, this is a reactive NST because we have 2 15 by 15 accelerations, and this is probably a 10 to 12 minute strip. So we've got 2 showing on here, and so for testing purposes, you can take the strip as your time. You don't need to kind of add anything up or anything like that. So you can assume that if you've got 2 accelerations on that strip, that is a reactive NST. Now, we've assessed the fetal heart rate A cells. Now we have to assess the fetal heart rate D cells. So we do have 1 D cell that you can see here. So the hardest ones for students to tell are earlies and variables because they kind of look like each other. This is probably technically a variable because it is kind of abrupt. I'm not going to give you ones on the test that are questionable. They're usually very, very, very textbook when I give you the ones on the test. So this does count as a D cell for this patient. Okay, so let's just go back over that one more time to make sure everybody's on the same page because that's a ton of information I just threw at you. So first things first, our patient is contracting. If we were going to check frequency, we would time between the beginning of this contraction to the beginning of this contraction. That would be frequency. Duration would be pick a contraction and count how long that one contraction lasts. So this patient is contracting. We're going to move on and assess our fetal heart rate. So our fetal heart rate, we've decided that we're going to look at this little section right in here. So 140 to 150 falls within the 110 to 160 parameters. Because it's 140 to 150, that's 10 beats of variability, so that makes it moderate. We have 2 15 by 15 accelerations, which makes it reactive, which is a fantastic thing. That means our baby is happy and healthy. But we do have 1 D cell that we need to address. Okay? So if we were going to document this, we would say fetal heart rate 140 to 150 with moderate variability, reactive NST with 1 variable D cell. Okay? Some other things that we assess in labor and delivery that you wouldn't obviously traditionally assess on just anybody would be a cervical exam. Now, I know that we're going to be online this summer, but it is not allowed for students to do cervical exams on patients, even if you're in your preceptorship. So let me just kind of put that out there just in case that comes up. But when we do a cervical exam, there's several things that we do check. So we check dilation of the cervix, which is how open it is. So it can be closed all the way up to fully dilated, which is 10 centimeters. We check the effacement, which is how thick the cervix is. So as the cervix starts to open, it should also thin out and not be as thick. So the picture on the bottom left kind of goes over that. We look at fetal, or not look, but we feel for fetal station. And fetal station is how far down in the pelvis the baby is descended. So if you think about, and I apologize because a lot of things I compare things to are food or food items, but I always think about the pelvis like a salad bowl, and the salad bowl is bigger on top and smaller on the bottom. So if you think about that as your pelvis, a 0 station is the bottom of the salad bowl. And to give you a little bit more frame of reference, if the baby was a +4 station, they would be crowning. So you'd be able to see the fetal head without even doing a cervical exam. So a negative station indicates they're higher in the pelvis. A 0 means they're at the bottom of the pelvis but have not come all the way through yet. And then your plus stations are going to be closer to the outside of the body. So the head has made it through the pelvis and it's now moving towards the outside of the body. We can also feel for suture lines in the baby's head and fontanelles to make sure that we do have a fetal head so that the presentation is vertex, because vertex means head down. So those are the 4 components that we typically feel for when we do a cervical exam. So dilation, closed through 10. Effacement, 0% to 100%. 100% is thinned out, so like a piece of paper. And then the station is how far in the pelvis they are, and then we do our best to determine if they are in a vertex or head down presentation. Big thing that you need to know for your intrapartum lecture is going to be your stages of labor. So when we think about labor, we typically think about stage 1, but you are going to have to be familiar with all the stages of labor. So stage 1 has 3 separate phases. So I want to make sure, because I'm going to spend a little time on this one. So latent phase of stage 1 is going to be 0 to 3 centimeters dilated. Students sometimes get very caught up in the other stuff that we can put in a scenario. For instance, I could tell you in the scenario that your patient is 2 centimeters dilated, having irregular contractions every 5 to 15 minutes. They're moderate in intensity, and the patient rates their pain of 4. That's all very important stuff to know, but if it's asking you about the stage of labor, it all comes back to the cervical dilation. So 0 to 3 centimeters is going to be the latent phase. So yes, we're going to do assessments and all of those things, but we also need to, if they're staying with us in labor and delivery, this would be a great time to go through the admission, go through all the admission questions that we have, do a thorough assessment, identify any risk factors that the patient might have, and then do some education about, hey, this is what's going to happen. Okay? Now you'll notice on the picture on the right side there's some overlap in the cervical exams. So for testing purposes, that's why I'm giving you a little bit different so that there is no overlap, there is no gray area. So 0 to 3 is going to be latent phase of labor. We're going to get them admitted, we're going to identify any risk factors, we're going to do a good head-to-toe assessment, and we're going to educate them on what to expect during the labor process, because they really shouldn't be hurting terribly at this point. It's not going to get better, it's going to tend to get worse. Okay? The active phase of labor is going to be 4 to 7 centimeters. During this phase, your contractions are going to get stronger, they're going to get closer together, they're going to last longer. All those things are very true, but when we're looking at staging it, it's going to be based on the cervical dilation. During this phase of labor is usually when patients will request pain medication, which we're going to talk about a little bit more a little later. So during the active phase, in addition to your ongoing assessment that you're doing, your vital signs, your fetal assessment, you're assessing their contractions, you're also going to be considering that they're probably going to need some type of pain management. Transition phase of stage 1 is going to be 8 to 10 centimeters. So in addition to assessment, you need to prepare for delivery, because it is going to happen, it usually happens pretty quickly. It is very, very common during the end of active phase or the early part of transition phase for patients to get nauseous and to throw up. So if they start vomiting, you should perform a cervical exam because chances are they've made some cervical change. So transition, you're going to need to prepare for delivery. So that means getting all the personnel, all the equipment that's needed so that we can safely deliver this baby. So latent 0 to 3, active 4 to 7, transition is going to be 8 to 10. Stage 2 is going to start when they are completely dilated and end with the delivery of the baby. So essentially it is the pushing phase. Stage 3 is the placental delivery. It is going to start with the delivery of the baby and end with the delivery of the placenta. And then stage 4 is what we consider recovery, and that's where maternal stabilization happens and they become more hemodynamically stable, or at least that's the hope anyway. That's what should happen. Okay, so those are your stages of labor. I can guarantee you there will be test questions on stages of labor, so make sure that you commit that to memory. All right, so when a patient comes in and they're in latent phase of labor, we said one of the big things that we have to do during that phase is going to be to do an admission assessment. So some of this stuff we would do for other patients as well, but some of it's going to be specific to our labor and delivery patients. One of the first things that we need to ask them is about gestational age. So how many weeks pregnant are they?